So we'll continue here to debride the capsule, also performing a synovectomy of the irritated joint capsule from the tear and the impingement. As you can see, actually underneath where his femoral head cartilage is, it's pretty good cartilage. This is not the same as the area on the acetabulum that was damaged. And this is typically what we see. We see the damage more on the acetabular side than the femoral head. But again, you can see that I go very straight over the area, not be curved anymore. So as soon as we get this cleaned up here a little bit, get our view a little bit better, ensure that we have complete access to most of the femoral neck with motion, we will do our osteoplasty to prevent any continued damage in the hip. And we've done a pretty good job here. We have pretty good visualization. So now we'll switch out to a high-speed burr, which will be performing the osteoplasty and resect the area of bone that's causing the impingement. Looks like a little piece of capsule still got up in there, so we'll get that out of there. Here's our burr. We're looking right at the line there where it transforms from going curve into the flat surface, which is the impingement. So this is our alpha angle that we see on X-ray. And again, we're extending the hip just enough. Now that burr is on, we're going to take our demarcating line here. Basically go through the cartilage down to the bone. And throughout this, while I'm doing it, we'll actually have fluoroscopy or the special X-ray in here taking some shots to make sure I'm getting enough bone and getting it really in the area that I want to. You'll see we'll come down actually quite a bit all the way to the side. We'll start maneuvering the hip, but I really want to take quite a bit of bone off here because we have quite a bit of impingement as we've seen on our preoperative planning. You can see we've gone down a good 4 or 5 millimeters right in it, just here in this area. And we will continue this distally down the femoral neck. He's only in about 45 degrees of flexion right now. So if we brought him actually up to 90 degrees, this whole area would be hitting where we just did our repair. You can see we're taking that down there quite a bit. Change our camera angle here so we can continue our osteoplasty down the neck. And you can almost see right there, we're continuing to go down until we actually hit part of the periosteum or the capsule of the neck. It's quite a big step off right there from his impingement down to his normal anatomy where his neck is. In addition to using, there's that piece of tissue, we'll need to get that out. In addition to using the special X-ray, we'll also switch portals here once in a while to view this resection from basically that portal up there to again assure that we're getting all the way down here and getting a different perspective. You still that still needs a little bit right there. all the way back. You can see where it still goes down right there. That's where it should be down to. So we'll clean that off a little bit. Again, using our x-rays to ensure that we're getting where we need to. And we'll switch back to our burr and continue resecting this area. Post-operatively, due to this, is we're going to put the patient on crutches for about 4 weeks with 50% weight bearing, which means they can put some weight on it, but not all. This is because we have weakened the hip itself by taking this bone off. This is a lot of the cortex of the femoral neck, so it does support quite a bit of his weight. So in the 4 weeks that he's on crutches, it will allow his hip to remodel and become stronger and prevent any risk of hip fracture if he slips or puts too much stress on it. This would be our main worry for complication. The other complication with this is what's called heterotopic ossification of bone. You can see from all these small pieces of bone that are being burred out, I'm sucking them up at the same time, but these can get trapped in the muscle around the hip, and also just from the portals that we make, it damages the muscle. The muscle can get confused. Instead of healing into normal muscular tissue, it can actually form some bone, and this can cause some stiffness of the hip. So occasionally we will watch for this and put people on medication to prevent this extra bone formation in the wrong area. As you can see, this is a pretty extensive process. That burr there is nearly 1/2 inch, and if you take that around every place we're going, we are getting probably about 50% around the neck throughout different range of motions. So that's a fairly significant area. You're looking at about a 2-inch width area right there. From where his impingement started down to the femoral neck. So here we've finished out. We're through the anterior portal, so you can get a different view, and we're moving his hip, showing that the impingement is no longer there. Flexing him up, he's about at 70 degrees right there, right where he would start impinging preoperatively. And here we have our margin of normal femoral head cartilage going to our osteoplasty area. And again, we're going to use this portal to assess and make sure there isn't any other area that we want to continue our osteoplasty. But this looks pretty good. The osteoplasty where we've done is down to what we call more cancellous bone, which is where it's red, rather than a harder or sclerotic bone, which is in the area of the impingement. And you can see here again our resection. And that's going all the way out to the lateral side. There's our repair with our anchors from before, where the impingement was before. And now that is resolved. And we're rotating the hip right now as well while he's in flexion to show that we again are not having any impingement. Again, the suction seal there is nicely restored. So I'm happy with this. Just about done here. We'll take some final pictures, extend his hip out. So now we're bringing his hip out into extension, and you can see again our margin where the osteoplasty was started, normal cartilage there when he is standing straight up. And that's basically the end of our operation.